From a primary care point of view, the people sat in front of you who are patients with a suspected cancer and you're not quite sure where it is, actually only a small proportion of those will finally end up with a label of cancer of unknown primary, and the majority of them will get diagnosed with a specific cancer type. The sort of symptoms that patients with malignancy of unknown origin or cancer of unknown primary may present with to primary care are the general non-specific ones. So it's things like unexplained weight loss, severe fatigue, or in some cases actual lumps or bumps which are not clearly associated with an organ system and organ type. So I think it's being able to recognise and validate that suspicion and say, okay, I have a patient with unexplained weight loss. This needs further investigation, and really I'm suspecting this patient has cancer, and that patient needs to be investigated in the same sort of timescale as somebody with a suspected lung cancer or a suspected breast cancer. And the nature of what the challenge in primary care is for this group of patients is that those pathways are more difficult to define and access. With most of these patients, it's sensible to do some routine screens in primary care, some routine blood tests, including full blood count and kidney and liver profiles, and to be guided very much by the patient's symptoms in terms of whether there are some site-specific investigations. So there may not be a strong component of shortness of breath or cough, but if there's an element of that there, then a chest x-ray is a sensible thing to do. If there is an element of pain that might suggest malignancy affecting the bone, then sometimes some plain x-rays would be useful, or consideration to a full myeloma screen if that side of things was a concern. And there is not one routine screen set to do, but very much the screen of looking for the patient who's anemic, looking for the patient who's got unexplained thrombocytosis, looking for the patient who's got abnormal liver function or renal function, again that's unexplained, may help point towards the right diagnostic pathway. Thrombocytosis as a potential risk factor for cancer is something that has recently been introduced into some of the nice guidance and referral pathways for site-specific cancer. In the setting of malignancy of unknown origin, it would be a warning sign that actually there may be an underlying malignancy, and should certainly lead to consideration of whether referral to secondary care for further investigation would be appropriate. An appropriate set of blood tests for a primary care physician to send for a patient with suspected cancer would be a full blood count, a renal profile, a liver profile, a calcium, and then consideration to ESR or a PSA in men if there's a suspicion of potential prostate cancer. But it is important to tailor the blood tests to the presentation in front of you, and we know that tumour markers other than PSA are actually not a good screen. They're not specific enough for most cancers, and as a primary care workup, it's therefore not advised that a panel of tumour markers are sent, although those are sometimes used in secondary care alongside other investigations. When you get your blood tests back, of course, there'll be a proportion of patients whose blood tests are actually normal, but it is important to recognise what made you send those blood tests in the first place and the fact that there still is a suspicion of an underlying malignancy for these patients. In secondary care at the regional cancer centres, there will now be a cancer of unknown primary or malignancy of unknown origin service, which is intended to take and investigate these patients that don't fit into any of the other clear diagnostic pathways. These services are defined by the NICE guidance for cancer of unknown primary and set up and coordinated on a network level. Something else that's worth considering is that some patients with cancer present with a DVT, and DVT in fact has a greater than 3% positive predictive value for underlying cancer. So it very much should be part of your thought processes when diagnosing and dealing with patients with DVT to consider investigating or referring for underlying cancer.